a company by the name Omnipad, didn't even have any tubes attached. It was a totally remote pump. Though there are several insulin delivery equipments available in the market, only fewer than 50% of people with diabetes achieve an adequate glycemic control. We can see from this chart that more than 50% of diabetes patients, even in the US, didn't have any control of glycemia at all. And the Incretins recent data have shown that control has been achieved in terms of controlling the blood pressure and the lipid values, but not the blood sugar values. And here comes the story of glucoregulatory hormones. As our Madhusudanan sir indicated in his introductory speech, until very recently we had only two hormones which controlled the glucose in the bloodstream. It used to be glucagon from the alpha cells and insulin from the beta cells of the pancreas. But in the recent times, we have one more hormone, that is amylin, again from the pancreas, and GLP-1 and GAP were discovered. GLP-1 stands for glucagon-like peptide 1 and GAP stands for glucose-dependent insulinotropic polypeptide. And these two, GLP-1 and GAP, are together termed incretins. GLP-1 and GAP. And here in this slide, the yellow colored amino acids are synonymous with the structure of glucagon. What are incretins? Incretins are gut-derived factors that increase glucose-stimulated insulin secretion. The term incretin is derived from these three terms: intestine, secretion, insulin. So there is some factor in the intestine which after a carbohydrate or a mixed meal gets stimulated, resulting in the production of some hormones, and after that this hormone will stimulate the secretion of insulin. And this was known in the 1900s, and some scientists called it secretin. But they tried to have intestinal extracts ingested orally, but it didn't produce any insulin. It was only in the 1980s that incretins, especially GLP-1, was isolated. What is the difference between GLP-1 and GAP? They are not the same. GAP does not inhibit glucagon secretion and does not slow the gastric emptying. These are the two important differences. We will come to that later. What is called incretin effect? What exactly is incretin effect? When we are ingesting oral glucose, it stimulates some factors in the gut, resulting in the production of gastrointestinal hormones. And this effect is called incretin effect. If you look at this cartoon, you can see the incretin effect and the beta cell response to oral glucose versus intravenous glucose. When a person is ingesting, here it is a normal individual without diabetes, when he is ingesting oral glucose or intravenous glucose, the plasma glucose values achieved after this procedure remains the same. But if you look at the C-peptide, which is a marker of insulin secretion, the C-peptide levels, these are the yellow ones, are much higher when compared to the C-peptide levels after IV glucose. Incretin effect is a robust increase in C-peptide levels after oral ingestion of glucose. Again, here you can see the incretin effect and the higher amounts of insulin being secreted after oral glucose. But here, in this chart, you can see that both after oral glucose and after IV glucose, the incretin effect is blunted. And this loss of incretin effect occurs in diabetes. Here you can see the comparison of the incretin effect in a normal glucose tolerant individual that is somebody who is not having diabetes, and here is a subject who is suffering from type 2 diabetes. In normal glucose tolerance, the incretin effect reaches around 73% compared to only 30% in somebody having diabetes. So the incretin effect is impaired or is lost in type 2 diabetes. GLP-1 is an intestinal hormone. GLP-1 is secreted from the L cells in the intestinal mucosa, and these are from the distal intestinal mucosa. What are the major actions of GLP-1? These are very important in clinical medicine. Number one, it stimulates insulin secretion. Number two, by virtue of its action on the alpha cells of the pancreas, it suppresses glucagon secretion. There are incretin receptors or GLP-1 receptors in the alpha cells. It delays gastric emptying. It enhances satiety. It enhances beta cell mass and replication in most of the animal studies. But there is one limitation to the use of GLP-1 in clinical medicine. It is rapidly degraded by protease enzyme, serine protease enzyme, dipeptidyl peptidase 4, abbreviated as DPP-4. So the incretins or the GLP-1 are very good as a treatment for diabetes. But the limitation to the use of GLP-1 is the fact that it is rapidly degraded by the enzyme DPP-4. Though GLP-1 is secreted by L cells in the distal intestinal mucosa, the secretion of the GLP-1 starts when food reaches the proximal intestine. In other words, it's not the physical contact of the food with the intestine which is responsible for the secretion of GLP-1. There are some neuronal signals which are activated when food reaches the proximal intestine, and there are efferent nerves which are responsible for this signaling and thereby resulting in the secretion of GLP-1 from the distal intestine. The normal fasting level of GLP-1 is 5 to 15 picomoles per liter, and the normal post-meal value is up to 20 to 30 picomoles per liter. It's a simple cartoon where we can see after a mixed meal there is an intestinal GLP-1 release, and you can see the active GLP-1 pool. And here is the enzyme DPP-4 which inactivates the GLP-1, and this is converted to the inactive GLP-1. Unfortunately, 80% of the GLP-1 pool is the inactive pool. This is bigger than this pool. And the half-life of GLP-1, that is the active GLP-1, is only 1 to 2 minutes. And the inactive GLP-1 as well is rapidly excreted through the kidney. So if you can have some measure by which you can inhibit the dipeptidyl peptidase 4, you will have more of active GLP-1 remaining in the bloodstream. If you look at the pathophysiology of type 2 diabetes, type 2 diabetes is a diabetes which is present in more than 96% of our population. We have, as I have already said, we have medications to address insulin resistance. We have medications to address acute beta cell defect like glimepiride, glycoside, the sulfonylureas which can stimulate the beta cells to produce insulin. But we don't have medicines to address two factors, that is the high glucagon secretion in type 2 diabetes and the chronic beta cell defects which are progressive in type 2 diabetes. If you look at the medications available at present for addressing the insulin resistance, which are a major pathophysiological mechanism underlying type 2 diabetes, we have two important groups. One are the TCDs and the other metformin. Metformin is good in the sense that it will result in weight reduction in obese diabetes patients. But the weight reducing function of metformin doesn't sustain. Usually it will remain only for the first 6 months. When you compare metformin with thiazolidinediones as an insulin sensitizer, TCDs are 10 times more potent than metformin as sensitizers. And when we are giving rosiglitazone, we all agree that the peripheral edema prevalence is much higher. And the side effects of rosiglitazone can be nullified or minimized by combining it with metformin, if possible in fixed drug combinations. And the adverse effects of metformin, like weight loss or abdominal discomforts or abdominal bloating, can also be minimized by combining it with rosiglitazone. And at present we have, as I have mentioned, a couple of good drugs which can address insulin resistance. But there are currently unaddressed defects in type 2 diabetes, which are probably more important and probably much more difficult to control or treat. What are they? One is hyperglucogonemia. Second is accelerated gastric emptying. And third is loss of incretin effect. If you look at hyperglucogonemia, this factor or phenomenon was discovered 30 years back. Glucagon secretion is not suppressed after a carbohydrate-rich meal in type 2 diabetes subjects, but in normal individuals with normal glucose tolerance, glucagon secretion is suppressed after a carbohydrate-rich meal. And now it is being observed that this abnormality in the glucagon secretion not only appears in type 2 diabetes, but in fact it starts at a much earlier stage in pre-diabetes itself, when there is an impaired glucose tolerance or when there is an impaired fasting glucose. In other words, when the fasting glucose reaches 100 milligram percentage and when the 2-hour postprandial value reaches 140 milligram percentage itself, this hypergluconemia starts. Dysregulation of gastric emptying. This is another unaddressed mechanism in the pathogenesis of type 2 diabetes. Gastric emptying is a very key factor in the postprandial glucose excursions, because in type 2 diabetes there is an accelerated gastric emptying. When there is an accelerated gastric emptying, the food particles which reach the intestine much more faster and the nutrients will get absorbed from the intestine much more rapidly. And when these nutrients are absorbed rapidly, the blood glucose also rises inappropriately. And there is a mismatch between glucose appearance and glucose disappearance in type 2 diabetes. When compared to a normal person, in normal physiology, the gastric emptying becomes accelerated only when the blood glucose falls, so that the hypoglycemia is rapidly corrected and the blood glucose level reaches normal. Currently we have no drug available in the market for the treatment of diabetes which can also correct the accelerated gastric emptying in type 2 diabetes. Then the loss of incretin effect. The potentiated insulin secretion after oral ingestion of glucose is attenuated or lost in type 2 diabetes. We have already seen that. In type 2 diabetes, the GLP-1 levels are reduced in response to meal, and GIP is either normal or increased. And since GIP is not probably responding in type 2 diabetes, or probably is resistant, the major target of therapy now is on GLP-1 and not GIP. And that is why we are interested only in GLP-1 and not GIP. What is glucose-dependent enhancement of insulin secretion? The term glucose-dependent enhancement of insulin secretion means the enhancement of insulin secretion in a normal individual should be dependent on the amount of glucose which is ingested orally. And this is mediated via the hormone GLP-1. The insulinotropic action of GLP-1 is glucose dependent. This is a major advantage if we can use GLP-1 for the treatment of diabetes. In other words, it means that GLP-1 will start acting only when the blood glucose value is more than 90 milligram percentage. In other words, if the blood glucose is normal or if the blood sugar value goes down to 90, then the insulinotropic effect of GLP on the beta cells diminishes and stops. So there is no risk of any hypoglycemia which can happen with the treatment of GLP-1 in diabetes. And this exactly is the reason why GLP-1 and DPP-4 inhibitors, the two important drugs now going to be in the market very soon, are entirely different from the currently available oral drugs. The suppression of glucagon secretion is again glucose dependent. There are GLP-1 receptors on the alpha cells of the pancreas. We know that the glucagon secretion in type 2 diabetes is responsible for hepatic glucose production. When there is excess hepatic glucose production, which is not dependent on the amount of glucose ingested or present in the blood, that will result in fasting hyperglycemia. And in glucose dependent suppression of glucagon secretion, which is mediated by GLP-1, it is strictly glucose dependent. And the glucagon secretion is inhibited. Reduction of food intake, another unaddressed defect in type 2 diabetes. In animal models, GLP-1 reduced food intake and body weight. Probably GLP-1 is mediating some receptors in the hypothalamus. GLP-1 receptors are present not only in the pancreatic beta cells and alpha cells, the receptors are present even in the brain and in the hypothalamus. So probably GLP-1 is acting on the brain so as to produce satiety. Is diabetes a disease of deficient appetite signals? That is a new thought with obesity on one end and with the type 2 diabetes and insulin resistance with beta cell defect, and here we have reduced GLP-1 levels. Some of the human studies. In humans, GLP-1 is now proved to increase satiety in both lean and overweight subjects. There is a feeling of fullness after eating so that they will stop eating. This is a major advantage in treatment of type 2 diabetes. This is supposed to be an extraordinary mechanism of GLP-1. How to use GLP-1 for treatment? Is it possible? Because GLP-1 cannot be used for treatment of diabetes because it will be rapidly destroyed by DPP-4 inhibitors. The half-life is only 1 or 2 minutes. And we have two options. One is to use incretin mimetics, analogs, which have a molecular similarity with incretins. And the second option is to use DPP-4 inhibitors. Both are available. The two incretins are exenatide and liraglutide. In one of our previous CMEs, we had one session on exenatide, which is otherwise called Byetta, already in the market in US for 1 year. Exenatide is a synthetic version of exendin 4. Exendin 4 is a hormone which is present in the saliva of this Gila monster, otherwise called Heloderma suspecta. This Gila monster or this Heloderma, which is native to some of the southwestern states in US, is so unique that it will eat only 4 times a year. And on other occasions, when it is resting, the pancreas is switched off. And Incretin 4 is isolated from the saliva of this Gila monster. Incretin 4 is derived from exocrine hormone with endocrine properties, since it was isolated from saliva, not from an endocrine gland. And this structure of exenatide is so different from GLP-1 in that it resists the proteolytic activity of DPP-4, and hence it won't be degraded by the enzyme which degrades GLP-1 and GLP. It can bind to the pancreatic GLP-1 receptor just like GLP-1 can adhere to, and the action lasts for around 6 hours. And exenatide, like GLP-1, will act only when the blood sugars are high. The insulinotropic glucagonostatic effects are the same as GLP-1. It has the ability to suppress glucagon based on glucose levels. The only side effect of exenatide is a dose-related nausea. It is used as an injection 5 micrograms to 10 micrograms twice daily. Another major advantage with exenatide is the sustained weight loss observed with the use of this injection. A blessing to the type 2 diabetes patients. The weight loss is not short-lived, but it is sustained. And there are several studies available with the use of exenatide in combination with metformin, sulfonylurea, metformin and the sulfonylurea, and you can see that when the dose of exenatide is increased, there is a level of A1C which is coming down. I already discussed the pharmacology of exenatide. The major advantages are that it slows the gastric emptying, which is abnormal in type 2 diabetes, and it suppresses the elevated glucagon levels, and it enhances the glucose-dependent insulin secretion. There is another GLP-1 analog, which is a human analog, which is going to be introduced very soon. That is liraglutide from Novo Nordisk. The advantage of liraglutide is that, unlike exenatide, this drug need to be administered only once daily. And another advantage is that it can be used once daily. Incretin mimetics are different from insulins, that it will not enhance insulin secretion or suppress glucagon during hypoglycemia. This is one major problem that we face every day, whether it is insulin or oral hyperglycemic events. If the dose is excess and if the patient has got a low blood sugar value, there is no automatic sensing mechanism. But with the use of incretin mimetics, there need not be any fear of profound hypoglycemia. And when compared to exenatide, liraglutide can be administered once daily, and counter-regulatory hormones are not affected during hypoglycemia. These are the extra pancreatic receptors available for GLP-1. Some of them that I would like to highlight will be increase in cardioprotection and increase in cardiac output. Some of the areas which are still under observation and study. And in pancreas, it can increase insulin secretion, reduce the glucagon secretion, and these are the areas which have attracted much attention, that is increased beta cell proliferation and neogenesis, and a reduction in beta cell apoptosis. These are the next group of drugs available orally. They are similar to the cell surface marker 26, which activates the T lymphocytes, a mediator of immune system. They are called the DPP-4 inhibitors. We have several DPP-4 inhibitors. They are the dipeptidyl peptidase 4 inhibitors going to be introduced in the market soon. Two of them will be introduced very soon, that is vildagliptin and sitagliptin. The trade name of sitagliptin is already announced, that is Januvia. Dipeptidyl peptidase 4 is rapidly inactivated by removal of histidine and alanine. And we have inhibitors for this dipeptidyl peptidase 4 so that Instead of inactive pool being bigger one, we have the active GLP pool, which is much bigger than the inactive GLP-1 pool. And here, the studies with the vildagliptin, when compared to placebo, this drug has resulted in higher levels of GLP-1 in both animal and human studies. These are some of the studies where DPP-4 inhibition increases the active incretin levels. And they have used the DPP-4 knockout mice, and here you can see the DPP-4 knockout mice in comparison with the wild type mice. And the DPP-4 knockout mice appear to be metabolically very stable, and it didn't have any abnormal glucose tolerance. Insulin secretion is increased with the use of DPP-4 inhibitors. And the use of sitagliptin, which is going to be in the market within a couple of months, it reduces the pro-insulin ratio. And another remarkable finding, but this finding is presently only with some animal models. We can see the beta cell replication, reduction in apoptosis, and a marked increase in the beta cell mass with the use of vildagliptin and sitagliptin. If these observations are going to be the same in human beings, it is going to be a remarkable achievement. Already there are observations showing that in human beings also the beta cell mass is increased with the use of GLP-1 and DPP-4 inhibitors. DPP-4 inhibitors are remarkably safe. There are no major adverse effects. The adverse effects are not different from the placebo. There are no significant changes in laboratory tests. There is only a very low degree of hypoglycemia, especially when they are combined with the existing drugs like sulfonylureas. DPP-4, unlike the GLP-1 analogs, will not help in body weight reduction. But there is an advantage being that they are body weight neutral. At least they are body weight neutral. They also inhibits glucagon secretion, improves the beta cell function, reduces the blood sugar values, reduces the postprandial lipemia. Unlike GLP-1, there are two differences. That is, they have no effect on the accelerated gastric emptying, which is seen in type 2 diabetes. And they have no role in the control of body weight, except that it is body weight neutral. But DPP inhibitors, until now, in almost all the studies, proved to be extremely safe and tolerable. For the sake of completion, some areas where some new things are happening in the management of diabetes. We have the endocannabinoid system recently discovered, and we have cannabinoid 1 receptor blocker already available in the market in the US. And the name of this medicine is Accomplia. The pharmacological name is rimonabant. And this rimonabant is used for the treatment of lifestyle illnesses. It regulates energy balance, thereby reducing the food intake. It reduces the body weight. It has got a control over the lipid and glucose metabolism, hence found to be very useful in dyslipidemia and type 2 diabetes. And this drug can also help with smoking cessation. Already available in the US, but our present discussion has got nothing to do with endocannabinoid system or cannabinoid 1 receptor blocker, but only for the sake of completion, since we are discussing about newer happenings in diabetes. And the first inhaler insulin was very recently launched in the US. The trade name is Exubera. We have a couple of other inhaler insulins to be introduced in the market very soon. This is how it looks like, and this is how it looks like when it is expanded. And this is the spacer device, and this is the inhaler part, and these are the parts of the Exubera inhaler. We have medicine which is available as blisters. Here we can see the blisters as 1 milligram and 3 milligram blisters. And insulin is available in the powder form in the blisters. And this insulin has to be introduced like in a rotacana, like rota capsules, and you can crush the powder with this handle, and the powder will appear in the spacer, and this can be inhaled. Inhaled insulin is only a rapid acting insulin, and this insulin has to be taken at least 10 minutes before food. This is not a basal insulin. Inhaled insulin cannot be used if the patient is a smoker or if there is an underlying lung disease. And before prescribing an inhaled insulin, it is mandatory that the patient should undergo pulmonary function test. Experience teaches only the teachable. Thank you very much for your patient listening.